Okay, let's get started. Okay, hey everyone, it's Ben here with IV Therapy Startup. We have some industry experts with us today. We have Dan Powell with Olympia Pharmacy and Sarah Sheikman with Lingia Law and Allison Powell with Lingia Law. So maybe to get started, maybe briefly, we'll just have Dan, Allison, and Sarah introduce yourselves. So maybe we'll start with Allison. Go ahead and introduce yourself and who you're with.
Yes. Hi, everyone. So as been said, my name is Allison Powell. I am an associate attorney for Lingia Law. So I'm excited to speak with you all today about USP 797 and IV hydration regulations. I have been working for Lingia for almost 3 years now, and so we primarily focus on medical spas and IV hydration businesses. So we've seen a lot of changes just in the last 3 years in this industry. So we're excited to speak to you about it today.
Cool. Great. Sarah?
Hi, everyone. My name is Sarah Schickman. I'm the managing partner here at Lingia. Super excited to talk to you guys about USP 797 and happy to answer any questions you guys have.
Cool. And Dan?
Hey guys, Dan Powell, Director of Business Development with Olympia Compounding Pharmacy. We're both a 503A and a 503B pharmacy. Excited to be on the call with Lingia. Obviously, there's been a lot of changes in 797, especially since November of last year, and a whole bunch of different things going on with different states. So it's good to have them on here to explain from a legal standpoint what you should look for, what you can and can't do.
Mm-hmm. Cool. Yeah. Thank you guys for being with us today here. So I think just to get started and for the sake of time, maybe Dan, if you want to give us a quick overview of, we've had discussions on this before, of course, just kind of some of the questions that are out there and challenges that clinics are facing. Because I think it's our mutual goal to help everybody be compliant, safe, and profitable in this business. So if you could give a quick overview of what we've already kind of been discussing.
Yeah, as I mentioned before, the IV business is booming, it's growing, and it's a very profitable business. The patient outcomes are fantastic, but because and like I said, everybody on these calls, we're all kind of pioneers in this business. As we're pioneering it, obviously there's hurdles. The states are trying to regulate it, federal's trying to regulate it in the name of patient safety, and we're all just trying to do the right thing, stay in our lane, make sure we're following the regulations, but they vary so much. They vary from state to state. 797 talks about compounding, which is clear. If you're a compounder, you have to do certain things, but what's not so clear is what does your particular state, how do they decide whether you're compounding or not? So I think for me, from where I sit, that's the big gray area. It's like, oh man, a lot of the states are different. So it's good to be on with a team of legal experts who handles this, that can maybe give us all some insight and direction on what the heck is going on and what do we need to look for.
Right. Yeah, no, that's I think that I don't really have much to add to that. That's kind of, yeah, what we've been discussing to this point. So maybe Allison and Sarah, if you two want to kind of bring us up to speed or give us your take with USP 797 and from your point of view, like what that means for clinics and how people can comply with that.
Sure.
Allison, you want to go ahead?
Sure. So I found a fun statistic. It's a little bit outdated, but at least 87% of boards of pharmacy either require full compliance with USP 797 or they incorporate USP 797 in some way into their state regulations. So even boards that don't incorporate 797, they consider it to be a standard of practice. So even if your state doesn't directly say you have to follow 797, it still could be kind of used as setting the standard of what you should be following. So and compliance and like awareness of what it is very important. But before you kind of get into USP 797, I think even more important is what your particular state regulations are. So whenever you're trying to figure out what's in your scope as an RN or another medical professional, you want to ask, what does your state practice act say? So in a lot of state practice acts do specify whether an RN can compound or whether they can follow a physician or mid-levels order to compound. And then it doesn't just get like, it gets a little bit harder from there, because not only are you subject to your state practice act, you also have to consider other boards that kind of regulate the same area. So if you're subject to the Nurse Practice Act, well, what does the Medical Practice Act say? Because if you're being delegated the procedure from a doctor, a doctor can only delegate what he's authorized to delegate, and then he has to follow the delegation requirements to delegate that order of the treatment. And then even more, there's the pharmacy board. And so certain state pharmacy boards have come out and said that only pharmacists are allowed to compound in their state. And then in addition to like the actual statutes, a lot of states have issued what they call board position statements or board advisory opinions. And honestly, those states are my favorite, because if I can find an actual advisory opinion, it makes my job a lot easier to tell my clients what their state is saying and what their state is looking for. So typically advisory opinions and board positions, they're not law, but they give you a really good idea of what a board is looking for and what they're going to hold up as the standard. And then, so once you figure out your state specific kind of regulations, then that's where you're going to then fall back to USP 797. And like I said, most states have either fully adopted it or they've kind of held it out to be a standard. So we want to make sure that we're complying with it as much as possible. You don't want to be a renegade here. You want to follow what is industry and nursing best practices, because if you do get an investigation or something goes wrong, you want to be able. I'm getting an echo for some reason, but you want to be able to say, okay, well, even if okay. You want to be able to say, well, even if I missed this regulation in my state, you can kind of fall back to the industry and say, okay, like obviously I want to correct this. I want to follow my state regulations, but I was following industry regulations. And that gives you a really good kind of ground to stand on, leg to stand on when it comes to talking to a board or investigator. Sarah, do you have anything to add?
No, I think that's exactly right. I think that it's an amazing field that's been growing tremendously, but the safest route is to comply with USP 797, even if in your state there hasn't been a specific position that says you have to comply, because what's been happening is, even in situations where it's super, super vague and there haven't been things issued in your particular state, if a competitor reports you to the board comes in to investigate, and you could still get in trouble. And at that point, it's much more expensive to try to fix it. So it's just better to have it be compliant from the beginning, and then work with a pharmacy like Olympia, who can basically ship you the products that you need in already a pre-mixed way. So you don't have to be in that situation where you're compounding and you have to do certain things. So we'll kind of talk about what 797 requires you to do, and then also how to work with somebody like Olympia to just get the products that you need so that you don't necessarily have to be compounding yourself.
Yeah, no, yeah, that's great. Dan, do you have anything to add to that?
Gotta find the unmute button there. Sorry. No, I think that's great. That's great advice. You know, and I think for the folks over at Lingia, so what we do, we don't sell the normal saline bags. So we will sell the vials. But what we are trying to do as a company is we see these regulations, and a lot of them are, okay, if you're compounding, one of the things that seems to be squirrely to nail down is how many punctures can you have into the bag before you're considered compounding. So what we're trying to do as a company is we're trying to combine as much as we can into a single vial. Now that has its own challenges that we need to worry about, like what can you mix in the vial, what can live together in harmony in the vial. And then this way the end user only needs to draw out of the vial and make one puncture into the bag. So in that, I guess I'll default to Lingia on that. If it's drawing out of the one vial and puncturing the bag, would that constitute compounding for that particular clinic, or does it depend on the state?
So it's definitely always state dependent. That's always going to be the legal answer. Unfortunately, there's no way to get around that. But so compounding has a super, super broad definition, unfortunately. So USP 797 defines sterile compounding as combining, admixing, diluting, pooling, reconstituting, repackaging, or otherwise altering a drug product or bulk drug substance to create a sterile medication. So I mean, mixing anything, whether you're mixing 1 ingredient, 2 ingredient, 3 ingredients, you're technically under compounding. There is a small exception where administration and preparation per a manufacturer's approved labeling is out of the scope of USP 797. And so that is more if you're able to follow someone like the manufacturers, like Olympia's directions on exactly how they're telling you to put the bag together from their label, then there's a small carve out from compounding. But otherwise, anytime you're mixing anything, reconstituting anything, it is technically compounding. I think some of the confusion with this is because the standards, like I said, they're so broad. But in practice, compounding's been done for years by nurses, especially in a hospital setting. Like it's very common for a nurse to prepare the IV bag for the patient that is recovering from surgery, or it's really common for a nurse to reconstitute other types of medicine. Like it's just something that they do every day, and you don't think twice, and you don't think it's compounding. And then you read the regulations, and you're like, oh, wow, it is. And in those type of settings, you're not really seeing much enforcement. The problem with IV hydration is states are very, very concerned about the safety of IV hydration and IV hydration businesses and patients that are getting IV hydration. So even though it's the same standards that have been used for years, now they're applying them way more stringently on the type of business that you're trying to enter into. And the law hasn't changed. It's always been that. But at the end of the day, the law is the law, and they can enforce it if they want to enforce it. And they can enforce it how they want to enforce it. And that might not be fair. But legally, that's how it works. So what USP 797 really focuses on is sterile ingredients. So Dan, to go back to your question, that a lot of times it's easy to focus on like the bag punctures. And that's kind of a good way to judge it is if you're doing immediate use compounding, you can mix together 3 sterile components. So if one of the sterile components is a multi-ingredient component, like a multi-ingredient vial for like a Myers cocktail or something like that, that's one sterile component. The bag of saline is its own sterile component. So you're already at 2, which means you can mix one more thing in, or you're going into a lot more complicated form of compounding, like category 1, 2, or 3. And when you start getting into category 1, 2, and 3, there's way more regulations, and it's way more likely to be out of your scope as a nurse.
That's great info. If I can maybe add on to that. So when you're when we're talking about the bag punctures and all that kind of stuff, when you get to the point where, and I guess like you said, it's very state specific. So what I'd like to give the group is like check with your state, see if you're determine if you're compounding or not. And then what after that step for me, what comes next, and because this varies from state to state, and correct me if I'm wrong on that, if you're compounding, the states again are different on this. Who needs to mix that bag? Like I've heard in some states, oh well, if you're crossing the line into compounding, then you have to have a pharmacist, or you have to register your business as a pharmacy. And then there's also the question of sterile hoods, laminar flow hoods. So can you speak a little bit about that? I know those are all very state specific items as well, but Can you maybe comment on that a little bit?
So there definitely are some states that have made really strict restrictions on what they consider to be compounding, and they don't want RNs mixing anything into the saline. Like they only want the nurse to be administering what is a pre-mixed bag, and that is really like it's hard to get pre-mixed bags, especially on a national level and in a mobile setting where you're having to transport these bags to different clients' houses or events that you're going and doing IV hydration at. In states like those, unfortunately, there isn't really much you can do to get around it. Like I said, there's the argument you could make that it's not compounding, but it's like it's like following a manufacturer's label. But if the state has, that's USP 797's regulation, and the state has more authority than USP 797 because states get to choose whether to adopt USP 797. So like if they add in an additional rule that is even more restrictive than 797, like you have to follow the state's rule. There is the small carve out too between like what's a board advisory opinion that's not actually binding law and what is binding law. But if it is a board advisory opinion, like do you really want to be the RN that has to spend thousands of dollars in legal bills trying to show why, even though the board has already kind of made their feelings clear on it, the board's wrong, and take that battle to the board. In states like that, I think a more effective way to handle it would be to try to get like a group together and go and advocate at your board for why you should be able to do this type of compounding, and how you're doing it safely, and see if you can get the board to kind of change their opinion. But that can take a long time, and at that point it may not be a worthwhile business for you. And again, that also takes a lot of time and money. So your best bet would be to find a pharmacy that can do a pre-mixed bag.
Mhm. I had a question, and real quick, if anybody has any questions, you can just put them in the chat there while we have, some more time here to get to those. But I had a question about doing a push, like glutathione push after. So you do an IV and you have your three components in the bag, but then when the bag's done and then you follow it with a push, is that considered another ingredient, or would that be on its own, or maybe somebody can help me with that? Because I've had that question a few times. I'm not sure how to answer that.
I could help you with that. So the law doesn't really speak to that exactly. The conservative approach would be that that is considered another ingredient. So I think that the safest approach would be to, at that point, just do a new bag with a maximum of 3 total things, and not do a push on an existing bag. Just because this particular situation isn't addressed directly, so there's going to be no one that can tell you like, okay, you could do this 100%. You can do it, but there's a risk that someone may say that at that point you're exceeding the number of ingredients.
Okay. There's some questions coming in here. So there actually was questions on that too. So doing a separate bag, that brings up a good point. I know people are saying that it's like one bag, one IV, and then the thought of doing another bag and puncturing another vein is kind of a no-no. I mean, there's probably I'm not the medical professional here, so I don't know the but those are just questions that I get. I don't know if there's any good explanation for that.
Yeah, I think a lawyer's explanation probably for this won't be a good one. Someone who's can make the medical decision can say whether doing a second IV with a second bag makes sense for that client and whether it's safe. we can't really speak to that. We could only just say like, this is what the law says. This would be the conservative interpretation, and there are 1,000 other interpretations for sure. It's definitely a developing field. So it's a place where a lot of things haven't really been tested at the nursing board and the pharmacy board level, where they haven't had to deal with this situation before. And so there isn't some precedent that says this is exactly what's going to happen.
And can you speak to immediate use at all? And how, I know people are, there's a lot of like mobile IV clinics and people like that, so they are mixing these ingredients, and just how long they have to use them, and how that process works with immediate use.
Yeah, Allison can speak to that.
So immediate use is 3 sterile components with a bud of less than 4 hours. So you have to use it within 4 hours. There are some other things that come into play with immediate use as well. So if you're doing immediate use compounding, you're required to have a protocol. That protocol has to have it has to speak to like your training, and it has to speak to like designated person in charge and how you actually are preparing the compound, what sterile like mechanisms that you're using to prepare it. And so it's like it allows you to do compounding in a more mobile setting, because it doesn't require that you have a hood or an isolator like category 1 does, but it's still it's more than just like, if I stick to 3 and I use it within 4 hours, I'm good to go. Like, you still do need to have like documentation in place showing that you're following the standards that immediate use requires.
Right.
Happy
we
to
have
answer questions on that.
Yeah, we have some questions come in the chat here. Maybe we can jump to some of those real quick.
If I can jump in
Go
real
ahead,
quick,
Dan.
something that Allison said. So what would be a good resource? Like documentation is important in the immediate use setting. What would be a good resource for the people listening? Like what type of, what needs to be in that documentation? Where can they find out how to put the documentation together? And because I know at Olympia, we have a lot of mobile IV clients. And those are questions like how do they get that documentation? Where's the starting point for them, I guess, is what I'm trying to ask.
So there are different organizations that have put together like different resources. Our law firm has a protocol that's available to purchase, or if you like sign on as a client, it's possibly even available complimentary. USP 797, if you dig through their website, it's not always the easiest to find, but they do have like some FAQs and different guidance documents that they've issued. And it's always good to go to the source instead of using like third-party organizations. Because again, like Sarah said earlier, it's so new. What you're getting a lot of times is people's interpretations of what the regulations are. And so if it's not directly from a very legitimate source like USP 797 or your state nursing board or something like that, like you do kind of have to read it very like with a grain of salt. So the SOPs that are required, they want to make sure that they show that aseptic processes are being followed to minimize contamination. So like, are you only wiping the top of the vial in one direction? And it gets nitpicky like that. And then also it should include like, what's the scope of immediate use compounding? What are the training requirements? So USP, you should be trained at least once a year. And it should include both hands-on training and also classroom training. there should be like a protocol on the appropriate selection of components and how those components are selected. You'll work on this in partnership with whoever your medical director is, whether it's a doctor in a state that has full practice authority, it might be an NP. And because they're also involved, because if you're an RN, it's not within your scope to like diagnose and order an IV hydration treatment, including the components of the IV hydration treatment. So all of this should have your medical director or your nurse practitioner involved. And then you want to include like the bud and the labeling requirement. So most of the time under under immediate use, you are just preparing it and immediately using it. So then you don't label it. But if you ever did have to store it, like if you walk away from it, it's supposed to be labeled. So if you're going to prepare it, put it in the fridge for an hour, whatever you put in the fridge for an hour should be labeled. And so that like the labeling requirements by USP 797 should be in your protocol. And then your protocol is supposed to be accurate to your practice. So it's a living document. So as you add new IV hydration recipes, if you change your like administration method, if you change like the training that you do, you would be updating that into your protocol. And then it's something that not only for USP 797, but really any nursing board, if they come about any treatment that you're doing, most of the time they're going to want to see your protocol. And then USP 797 with IV hydration just kind of adds different things that need to be in your protocol as well.
I had another question. So in regards to using a hood, I don't know if this was answered or not, but if we can only add, let's say in Arizona, 3 ingredients, for example, I know there's people out there that are pushing that you have to have a hood or you should have a hood. And I'm not arguing that you should have a hood because maybe you should have a hood, right? It's going to be a sterile environment, safer, and that. But even if you had a hood, it doesn't change what you can do. Like you can't start then adding more ingredients and doing different things, because that would be, you'd need to then have a pharmacist on staff, right, to be actually legally compounding. So what advantage or A, do we need a hood, and B, what advantage does a hood give you by having a hood versus not?
So A, these are the minimum standards. So there's not a hood or isolator that's required for immediate use according to the standards, but you can always do more than the standard. And like you said, having a hood or an isolator is going to make it more sanitary. And then as far as B, it goes back to what is considered to be in your scope of practice. So some states haven't like limited an RN to only being able to do immediate use compounding and only being able to mix 3 components. Some states say that like an RN can compound whatever a physician orders. So if a physician orders more than 3 ingredients, then they would have to have a hood or isolator to comply with USP 797, but then they wouldn't be violating their state regulations. If you do have a hood or a isolator, it increases what your obligations are in monitoring the hood and isolator. So you have to have like temperature logs, and you have to have an airflow generator that's going to keep the air flowing in one direction. There should be a segregated compounding area that is not just open to general public. Like it's supposed to be a separate area that only the people that need access to it have access to it. So just generally, we try to tell people to stay away from category 1 compounding just because it gets really complicated. But if category 1 compounding is allowed in your state and it is going to help grow your business and you want to do it, then it like you can do it, just make sure you're doing it right.
Mm-hmm. Yeah, that makes sense.
Question if
Go ahead, Dan.
So if you're in a state that requires you to register your business as a pharmacy. Or if you're, well, let me just stop there. So if you're in a state that requires you, because you're doing IV hydration, you got to register as a pharmacy. Does that then open that business up to be? I think the answer to this is yes, but does that then open that business up to be inspected by the Board of Pharmacy?
Yes.
Yeah.
And that's kind of the downside is they have a pathway that if you follow the pathway, 100% legally, you're not taking a risk, that they've approved it. But then you're subjecting yourself to more regulations. Again, my preference is I would much rather be in a state that gives very clear guidance and rules, even if they make my life a little bit more complicated, because then I don't have the stress of being scared I'm going to get in legal trouble every day. But I'm very conservative like that. Other people may be like, okay, my state doesn't really regulate it. I am just going to follow industry best standards and hope for the best.
There's some questions from Pam. Pam, are you with us? Maybe it'd be easier if you just unmuted yourself.
Oh yeah, I'm here.
Hi, Pam. Yeah, you had some questions in the chat. I think maybe it might be easier if you just ask
Oh yeah,
them.
that's fine. It'll be easier for me to explain. I'm an RN. I've been for over 20 years. I actually know Dan very well. Dan knows me. I'm the president of a very large mobile entity. One of the issues that we have is the nursing boards are taking pharmacy regulations and implementing them into the nursing world. Those regulations, when you talk with the State Board of Pharmacy, are like, yeah, our regulations are meant for us. They're not meant for physicians. They're not meant for nurses. So in a definition from one state, it says a nurse cannot compound, with all the definitions of compounding, to create a medication for distribution or sell. That's not what we're doing, because we are not taking, my example is Tylenol and oxycodone, putting that together, making a new tablet, and now we are distributing that or we are selling that. So in compounding in the pharmacy world, that's what they're discussing. In the nursing world, an example is why diluting is not the same thing is because I go on a nursing unit. My background is intensive care. I take morphine out of a vial. I put it in a syringe of saline. That's diluting. In the nursing world, that's just part of administration per the product guidelines. So they're two completely separate entities, but they're considered diluting. You're taking one definition that is meant for one person and giving it to another. So how would we attempt to help our boards understand the difference when the pharmacy boards are even stating it's two separate entities that we're working with? They're just trying to take the rules from one and put it into the other when it doesn't make sense, because that's not what we're doing.
What I would suggest, and I think that's a really good point. I think that's exactly what's happening. And I don't know if it's happening with, bad intent. I think it's more happening because this whole business is pretty new and there's a flood of new complaints that are coming into the nursing boards. Because what's happening is competitors are complaining against each other to the boards. So, and then the boards are like, oh, we have to investigate this, but we're not sure how. We don't have enough regulations. Let's write some new ones. So in this case, I think the only way to effectively fight this is to form some trade organizations and then ask the board to meet and educate them about it. Because I think if you come to them as your business and say like, hey, I'm Pam, I own, IV hydration business X, the first thing they're going to do is come inside your business and may find some things that they want to look into. So I think the only real way is to help the people on the boards understand this better by having an industry association meet with them and talk to them about it. And that association doesn't have to be 100 people. It could be 3 to 5. So it could be just you working together with other people in the business who are not your competitors, maybe from different cities in your state, and then coming in and meeting with the board.
Yeah, that's definitely a game plan for this year, because it's interesting when you actually put all the people together, legal wise, USP, the actual State Board of Pharmacy, nursing, and medical. they're all going to say, my board governs what I do. You can't take what a physician does and then give that definition to a nurse. They're two very different things. So yeah, trying to take a pharmacy board definition that is meant for a pharmacy and implement it into nursing, you're setting yourself up for a whole lot of issues of why they mean completely different things for two very different entities.
For sure. And what state are you in, Pam?
I'm in Arizona, and Arizona is one of the newest states to start coming out with some regulations. And Arizona Pharmacy Board, they actually did not implement the newest version of USP guidelines. So in our nursing board, we're going with, what are we allowed to do? And yes, we follow the current guidelines. Our company does at USP, but now with the new state regulations that came out, it seems like they kind of contradicted themselves in multiple areas, because they again say to create a new medication for distribution or sell. Well, that's not what they're doing. But then they further state that if you are following federal or state regulations and USP guidelines, then you're okay. It's like, well, which one is it?
Yeah, after Arizona
It's
came
hard
out
to figure out what do they mean.
Yeah,
Yeah.
that advisory opinion from Arizona is really strict. So I would say, you know, if anyone is doing anything that's falls within even any interpretation of that opinion, it would be good to just try to have an informal meeting with the board on behalf of a trade association and just try to explain to them like what is happening and why this doesn't make sense, and try to advocate for something else, because that advisory opinion, you know, basically says that a lot of things that are currently happening should not be happening.
Yeah, so the very interesting thing. So as soon as that came out, we went guns blazing to try to understand it. And that's when we reached out to the Board of Pharmacy, and they were like, yeah, this doesn't apply to you guys. This is meant in our pharmacy of how we do things. We're like, yeah, that's what makes sense. So, but we are following, it's like statute 2D that says to follow federal and state regulations in accordance with USP. And I was like, well, that's cool. That's what we're doing. So yay. But then at the other side, it says something wonky. So we've been kind of really doing a lot of research into this to understand what they mean, and to hopefully try to work with the board a little more for them to understand what we do.
Makes sense.
Awesome. Thank you so much.
Thank you.
Okay, thank you, Pam. Let's see if we have any more questions here. Nick, did you have a specific question? Anybody else have any specific questions? I know Dan's just got a few minutes left before he's got to jump into another meeting here.
So what is the actual guidelines then? Should we get a hood, or are you saying that if you're in a doctor's office, you don't have to have a hood as long as you don't have more than 3 ingredients?
The guidelines don't require a hood or an isolator if you're under immediate use. So you're using less than 3 sterile components and using them within 4 hours. That is just the minimum standard. So you can always get a hood or an isolator in an abundance of caution. If you do get a hood or an isolator, just make sure that you're following the standards for using a hood or an isolator as well. So you have to, like, it's not enough just to purchase it. You have to make sure that you're maintaining it and that you're you have the right maintenance logs, that you're ensuring that the hood or isolator is operating to the standard it needs to be operating.
Yeah,
Do
with
you
the,
know about how much that would cost? Like, what's the average cost for that? A hood and all the maintenance in a year?
So it varies a lot. If you do purchase one from an actual reputable medical equipment vendor. I've had clients send me hoods on Amazon and say, like, can I purchase this? I don't recommend using Amazon. When the board comes in, they're like, okay, tell me about your hood. Where'd you get it? You're going to say, okay, well, it came from Amazon. And they're going to say, okay, well, how do you know you even ordered something that works? So you can spend like up to a lot on them. I don't have an exact number. Just do your research, and maybe other people in this group might have some recommendations for you as well.
Yeah, I think the least expensive hood I've ever seen is about 1,500. And speaking from the pharmacy side, I know like for our laminar flow hoods, we have to, and Allison was exactly right. We have to have the maintenance logs. We have a company that comes in several times a year and does what they call smoke studies to make sure that the airflow is working correctly. I'm not sure if you have to go that deep if you're not in a pharmacy, but there are definitely some things once you bring that equipment in. There is maintenance logs, upkeep. You might have to you'll have to bring in a third party company to do all that the required testing on the hood to make sure that it's in working order. So just something else to keep in mind. It's not terribly expensive to have that done, but it is another expense. So you know they could pile up. So, maybe a good on in closing, and this is just kind of this is really a interpretation or an opinion. Like, where do you see and this is for Lingia, where do you guys think that with all the regulations and the change, all the stuff through all the hurdles we're having to clear, we still feel real good about this industry, right? Like it's going to keep growing and you don't see anything like in the future that's like, oh, they're just going to shut down IV hydration. I think maybe put everybody's mind at ease, say like as long as we're compliant and we pay attention and we form groups, we have these kind of conversations, we form the groups that could talk to the state boards, that we're in good shape.
Yeah, I think that the reason there is more regulation is because the industry is booming so much, and it's the natural progression. Like there's usually when something new comes out or a new use comes out, there's a year or 2 or 3 or 5 of no regulation, and then there's some regulation, and sometimes it's the wrong regulation. But it's a sign of a booming business. If it was a business that was dying or going away, there would be no new regulation because no one would be focused on it. So I think it's still there's still a tremendous amount of opportunity here, and it's certainly a booming business, and we see it from all sides. I mean, we work with a lot of private equity groups who are buying IV hydration practices. We work with a lot of financial investors who are investing a tremendous amount of money into these. We work with device manufacturers providing devices for these businesses. So all the forecasts say that this industry is supposed to have double-digit growth for the next 5 to 10 years at least, and maybe more. So I think we think the industry will definitely still continue to grow.
But yeah, and I think that's the important thing here. I mean, we're all of us here on this call are very heavily invested into the IV business. So it's good to know that, and like I think you hit on it. As the industry grows, regulators are going, oh my gosh, we got to make sure people are safe, and that's why they're doing all this. But like you said, you got the board of pharmacy, you got the medical board, you got the nursing board, and sometimes they just don't all work well together, and it's going to take a while for it to all come together, but I think it will. And I'm real grateful to have these kind of like Ben's Facebook group and you guys at Lingia and all the people on this call. If nobody cared, it would just be the 4 of us sitting here talking to each other. Nobody would be on the call. But we've got a bunch of people on here that are interested, like, hey, where's this industry going? What do I need to do to be compliant? And I think that's the important part here.
Mhm.
Hi, quick
Yeah, well
question,
said.
if I can. Oh, sorry about that. I saw in the chat that hi, it's Lydia. Thanks for holding this and having this invite. I know that the legal group offered some of the protocols. If we can either have that sent to the invite or have some more information about that, that would be great. I think there was some other person that commented that in the chat as well. I really appreciate that. Thanks so much.
So for Lingia, do you guys cover, just for people out there, do you guys cover all 50 states, or is there, how to like, how, if people need help, they want your guidance, how can they reach out to you, or how can they get in touch?
Yeah, we cover all 50 states for a variety of different things. If people want to contact us, they could just email us at info@ongialaw.com. We also offer a free 15-minute Zoom consultation. So if someone sends us an email, we'll send you a link to schedule that consultation. You could also do that online. I'll find the link and paste it here. But yeah, we can help either customize protocols for your practice. We have a set of template protocols that we have available that we sell. We have some templates that come as part of our membership to those people who are members with our firm. So we have a couple of different options. They're pretty customizable depending on what you're looking for. But I think the best thing is if you have a specific question for your practice, just schedule that free consultation. I'm gonna try to put the link in the chat. If it doesn't work, I think Ben can probably send it to everyone.
Yeah, it's there. Thank you. And I'll put it on the post in the Facebook group. I'll put all your information there too. So I'm sure the conversation will keep going. And also Dan's or information for Olympia as well. I see some comments too on how people can get product and this and that. Dan, what's the best way for people to reach Olympia or you as well?
You could email me directly, dan@olympiapharmacy.com, and depending on what you need, I'll direct you. If I can help you, I will, or I can direct you to the right department. But thank you guys. I got to jump off for my next call. But Lingia, thank you so much. That was awesome, Ben. Thanks for putting this together, and thanks everybody for being on there. Really love what you guys are doing and helping this industry, stay between the lines, I guess to say. So thanks a lot, guys. Take care.
Right. Yep. Thanks, Dan. Yeah, no, it's an exciting time for IV therapy. I know it's booming here. I see new clinics popping up everywhere. And I think Dan said it good. Like we don't want this fear out there. We want just allow nurses and providers to just be able to help patients. But of course, while being compliant, and that's where like Lingia can be a big help for you guys with that. Just making sure that, I mean, nurses and providers know how to care for patients, but making sure we're compliant, being safe on that end. So yeah, appreciate Lingia, appreciate you guys being here. Their contact information's in the chat. I'll also put it in the Facebook group on the post. And I know that there's going to be more questions coming. So if Allison and Sarah, if you're in the group at all, if you want to kind of monitor that discussion going forward, I know you do offer that free consult, which is great. So anything else that you guys want to add before we jump off here?
I don't think so, but it was so nice getting to speak with you all today, and thank you all for your time.